Hello everyone, how are you all doing? Now the topic we'll take is try in. Now the word suggests try in. So what are we gonna try intraorally is called try in. So now we have articulated the wax rim, we have arranged the teeth accordingly. Now that arrangement of the teeth has to be checked in the patient's mouth before going ahead with the acrylization. Now that's a very important step as this is the last step where a dentist can do the modifications without much manipulation according to himself, according to the denture's need and according to the patient's desire. So what are the purposes of try-in? So the purposes of try-in are, we need to know what is the patient expecting, what are the different corrections that is to be required, is there any problem in the fabrication of the occlusal rims in the arrangement of the teeth, aesthetic concern of the patient, is it functionally alright if it is having the retention, stability, support that the denture desires. Is all this thing right in this particular stage? We will further proceed. Now how to go ahead with checking of each things. Now one by one we will come up to first the lower denture itself. So first we will place the lower denture and check for what all things. We will check for the peripheral outline, that is if the buccal and the labial outlines are proper, if it is extending properly, if the lingual outline is extending properly, if the periphery of the entire denture base is being extended to the right amount of place where it is supposed to be. Like for example, if it is not extending beyond retromolar pad, if it is not extending too much below the alveolingual sulcus that we have recorded so that it will get dislodged by the floor of the mouth, if it is not too inside or too outside of the ridge or the neutral zone where we have arranged our teeth accordingly. We will also find out if there is any problem in the stability of the occlusal surfaces. Now how do we check for the stability? So the stability is checked with the help of your two fingers, the index finger and your middle finger. What you do is you place it onto the occlusal rim, the teeth which has been already arranged, and you press on one side and see if there is lifting of the denture from the other side. Similarly, you put a pressure with your next finger on the other side and see if the denture is lifting from the other side. That decides if your denture is stable in this position. If it is not, repeat the denture base and the occlusal rim, also the teeth arrangement. If coming up to the retention thing, how will we check for the retention? We will ask the patient to protrude his tongue outside. If the denture is lifting, that means that is overextended in the lingual area. We will ask the patient to purse his lip like this and see if the denture is again lifting out. That means it is overextended in the buccal region. By movements of the tongue, if the denture is lifting out, so that means again it is overextended. If the tongue is moving freely and doing all its action like touching the ridge, upper ridge, touching the rugae area and moving it to the buccal and the lingual areas, moving it from the left and the right side of the cheek intraorally, all these things are happening without displacing the denture. That means our denture is well supported, well stable and well retentive in its position. So these are all to be checked. Most importantly, our denture teeth that we have placed, the artificial teeth, should not be higher in position than that of the tongue. Why is that so? So if that is higher in position than the tongue, so the tongue will be uncomfortable while we are moving the tongue. So that has to be placed lower. So that is the reason that retromolar pad limitation 2/3 is important for the denture to be prepared. Now what are the heights of the occlusal rim that we spoke, how much it should be, and the tongue space. Now the tongue space is also determined and executed according to the neutral zone technique. So we told about it. That is what? That is that zone. Neutral zone is the zone which is having equal vector of pressure of the tongue as well as of the cheeks. So now equal vector of pressure where it is lying, so the teeth arranged in that particular zone will be giving less pressure both from the tongue as well as from the cheek based on the patient's tonicity of the tongue and movements of the muscles. Coming to the upper denture, which plays another very important role. Another important thing in lower denture is that the denture, when placed in the mouth intraorally, should not be seen higher above the lower lip. Coming to this point is very controversial, because what happens in older individual, that the lips tonicity gets decreased and it protrudes out. Similarly, so what will happen, the lower incisors are going to be seen more. So that depends from patient to patient, that you need to decide what should be the height of the anterior section of the teeth which is arranged. Coming to the upper denture. Now there are several things that is to be noted in the upper denture. Starting from the basic is your lip support. Now the lip support which is there in the denture should not be protruding this particular position. You need to check for the alar of the nose area. We need to check for the rima oris areas, and we need to check if these areas are high enough or it is inside. Neither it should be inside nor it should be outside. It should be pleasing appearance to the patient as well as that comforts the patient. So that is both by the dentist as well as patient which will govern this factor of lip fullness. Now coming to the other factor, that how much amount of teeth should be visible. When the patient is in physiologic rest position, the visibility of the teeth should be as minimum as possible. That may be around 0.5 mm. But when the person is speaking in phonation activity or in function, the amount of teeth that should be noted is 1 to 2 mm of display of the incisal edge of the teeth. So now that will be depending if that is the place where we will correct in the trying stage. If our teeth arrangement is not proper and appropriate according to the articulator, we will change it in the patient's mouth intraorally. Coming to the peripheral outlines of maxillary denture base and the maxillary denture which we have prepared. So again we will check for the buccal area, we will check for the palatal area. We will check if there is any overextended. Underextended is hardly possible in denture, but overextended if it is there in the posterior palatal seal area. So now how we do that? We mark with the indelible pencil the hamulus notch, and that we will extend to the posterior nasal spine. We know that, and by asking the patient to speak ah in a very short burst motion. Then we will ask the patient to say ah in vigorous motion. So that will decide the anterior vibrating line and the posterior vibrating line respectively. So once that is decided, now we will place our denture base and transfer that mark into the denture base. So that will give us if the denture base is overextended or underextended. In this stage, still we can do the corrections which is required in the posterior palatal seal area. Also coming to the flanges, none of the flange except then the mandibular buccal should be heavier, thicker, because that will not only lead to protuberance of all the section, but also it will give some bulk to the denture which is not required. So, and that will also dislodge our denture. And again we will check for the stability of the denture with the help of two fingers. We will put one finger and see if it is moving from the other side, lifting from the other side, or talking from the other side. So these things to be checked in the maxillary denture base. Now by putting both the dentures, there are several more things that has to be checked. Once both the dentures are placed, now the first thing that is to be checked and the most important thing and the place where maximum mistakes happen is the occlusal area. How do we check if the patient has got the proper occlusion? By placing both the rims as well as the teeth arranged on it. Put both the index finger in the buccal shelf area of the denture base and then hold it firm and ask the patient to close the mouth slightly. The first contact which a teeth is going to happen, wherever the first contact is going to happen, ask the patient to stop over there. That contact, the first little contact, is called the feather light touch contact, which should not be present on single tooth. It should be equally divided in all the tooth. That means when the dentures are coming together and the first meeting point should be equally divided, distributed force on all the teeth. If it is on single teeth, single cusp, single fossa, you need to do a grinding, selective grinding later on. So rather, now we will have the place to correct it. Right? So that is first thing. Second thing that we will check is if the occlusion after holding it in the buccal shelf area with the help of your two index finger and closing the patient's mouth is properly occluding based on the patient's anatomy of the ridge. Now if the ridge is arranged in class 2 or in class 3 relationship, skeletal class 1, class 2 or class 3, our teeth arrangement also varied according to class 1, class 2 or class 3. So hence the occlusion will also vary according to the patient's skeletal class 1. There will be different occlusal scheme, will be different for class 2 and respectively class 3 also. So we need to check for those things. What else are we supposed to check when we are putting both the dentures? The very important another thing which comes very straight to our eyes is the midline. Now a great controversy was there, where exactly should be our midline? Will it should be with the philtrum? Will it should be with the labial frenum? Will it should be with the middle of the nose? Or will it should be with the glabella? Or will it should be with the interpupillary line bisecting from the midline or the mid-sagittal plane? So many confusions all cleared out with some simple easy tricks clinically was based on the patient's facial profile. Like if my face is this, divide it into two halves clinically and then mark it directly onto the wax rim. So that time when we have marked it in the wax rim, that should be the midline of our maxillary central incisors. Similarly, that has to be transferred to the mandibular central incisors. Studies have shown that mandibular midline and the maxillary midline do not match. True, but in maximum cases, if you match the maxillary and the mandibular midlines, they look very aesthetic in appearance. So, also to find out the center point, this was the best ever method which could have come out, not based on the frenum, not based on the philtrum, not based on, philtrum is what? This is philtrum. Frenum is where? Inside. And not based on these structures, but based on the facial midline, your denture should be there. So we saw how the midline was supposed to be. Now coming to one more important factor, what if there is a tilt in the central incisors? So the even tilt should not be there. The central incisors, as the arrangement says, it should be according to the arrangement. And also the line of the central incisors passing through the canine, that line should be parallel to our interpupillary distance. That is the anterior reference point. While we saw while arrangement of the teeth, that has to be kept into the consideration. So these are all the features that we need to find out. And also one more important thing that governs the maxillary trine will be the phonation. Other than aesthetic, the speaking quality also will be decided according to the maxillary denture base and the maxillary teeth which is arranged. That is, we will find out what are the things that we need to check to see if the phonation of the patient is perfectly fine. So we know now profile and lip form, we know about the amount of tooth visibility, we now know about the phonetics that we will talk in some time. Freeway space, we all know what is freeway space. It is that space which is present between the vertical dimension at occlusion and vertical dimension at rest. 2 to 4 mm of freeway space should be present in every and any individual in spite of whatever vertical dimension is there in that particular patient. Freeway space should be maintained to 2 to 4 mm for the betterment of the patient and quality denture delivery or placement from the dentist. And approval, of course, by the appearance of the patient. Coming to the tongue space, we all spoke about it. That tongue space should be present. Neither it should be very much encroaching towards the tongue, nor it should be towards the cheek. It should be in the neutral zone present in the patient's mouth based on the proprioceptive responses given by the patient, and intraorally whatever the patient is giving, its zone which is equal in the vector pressure of both should be arranged. The teeth should be arranged in that position, so that will not give us any other further future problems. Coming to the height of occlusal rim, again we spoke about it for the maxillary, how much it should be. It should be not beyond that of the maxillary tuberosity Also, it should be 1/3 from the Stenson's duct. Many of they say it should be all, but whatever it matters, it should be within the parallelism of the posterior reference point. Now, what was a posterior reference point? It is the ala tragus line, which we know, that is from the ala of the nose to the tragus middle part or the upper part of the tragus. We draw a line and the maxillary posterior region should be parallel to that particular line. What is the significance of ala tragus line? Also known as Camper's line in UK and known as Bromell's line in US. So what is the significance of these kind of lines? Now these lines are nothing but signifying the base of the skull. So maxillary rim, the maxillary teeth should be parallel to the base of the skull. That is a spatial relationship that we are gaining of the maxillary with that of the base of the skull. The next is position of occlusion. So horizontal relationship, we need to check when we are checking the occlusion that whether it is seating in the centric relation and centric occlusion. We all know by now that the centric relation and centric occlusion coincides in case of complete denture patients. I repeat, in complete denture, edentulous totally patients, the centric relation and the centric occlusion coincides, whereas that does not happen and holds true for a fixed partial denture patient or me or any patient who have got their teeth present, because there will be a freedom in centric. There will be some difference in centric relation and in centric occlusion. We all know by now about it. So we need to check about that it is properly occluding in the centric relation position or the centric occlusion position, which is same in case of complete denture patients. Check for the vertical height. For anterior in the mandible, we will check how much is required to keep the incisors posteriorly, nothing more above than 2/3 of the retromolar pad, because it is an inclined area where the occlusion force will not be directed perpendicular. Coming to evenness of occlusal contact, we saw even how to do that. That is the feather contact that I spoke about. That is when we are asking the patient to close the mouth with the help of 2 index finger placed in the buccal shelf area and the patient closing firmly. That means the first contact which comes should be equally of all the teeth of maxilla and mandible. It should not be on one single tooth or 2 single teeth. It should be on every teeth equally. Feather-like contact should be there in closure of the mandible. Coming to appearance, appearance has to be approved both by the patient as well as dentist. Now, the appearance as such, if sometimes a patient wants, no, I want to have, doctor, the teeth as it was before. Now, his teeth or her teeth before was central incisor, one placed little buccally, one central incisor placed or turned little on the mesial aspect. So, you need to protrude and reciprocate the same kind of thing which he or she had in his or her original tooth in the denture itself, because they want to look alike. Many patients says, no, give me an ideal denture. So that again differs from patient to patient, and according to that we will decide the appearance of the maxillary and the mandibular region teeth. Some patient even says, doctor, give me some space between each teeth, because older, when my actual original natural teeth was present, I had space. I want to maintain the same in the denture. So you need to maintain and reciprocate the same kind of features in the denture while in the trying stage, because that is the final stage where maximum corrections ought to be done based on the experience of the dentist as well as the requirement of the patient. Centerline, we spoke how we mark it. It should not have any tilt. The center should match with maxillary and mandibular central incisors. If it is though not matching, it should not be very varied, it should not be very outside, but at least some near about little acceptable changes are there, because in 90% of cases our own natural midlines do not match of the maxillary central incisors with that of the mandibular central incisors. Coming to the anterior plane, there should not be any tilt. In the anterior plane, the interpupillary line drawn should be parallel to that of the plane that is there, and also that plane which is there, that has to go along with the smile. So when the patient is smiling, you need to also see if the canines are not drooping down, giving a dragon-like or a Dracula-like appearance. We need to find out if that is aesthetically pleasing. To some patient, they want one canine to be a little protruded outside. So that depends on patient to patient. Otherwise, for an ideal arrangement of the teeth, we need to maintain these particular feature. Coming to profile and lip form, again this profile has to be seen. Where do we see the facial profile? We always ask the patient to turn on one side, and then we see from this side how is this protruding out. So again, the lip form, in the same way, the lips, if it is short lip, if it is high lip line, I told you how we are going to decide for what should be the length of the rim. That will decide where the incisors and the laterals and the canines are falling out. Amount of tooth visibility, we again spoke about it, that when in speech, in phonation, it should be 1 to 2 mm. Coming to rest, it should be nothing more than 0.5 mm. Some patients do require saying that we do not want the centrals of the uppers to be seen. Those are the old age patients. So in those patients, we can keep the mandibular anteriors in little higher position than that of the maxillary. So the thing which will be seen while talking will be the lower incisors, not the upper incisors. So that depends on patient to patient and the desires of the patient basically. So we need to take the history. The expectation of the patient should be well clear in patient, in the dentist's mind, before fabricating a denture, so that that can be reciprocated and the patient will be satisfied accordingly. Coming to the best important and the most important thing, that is the phonation. Now, what is phonation and what are the things that we're supposed to check? Phonation, the first thing that you're supposed to check is the bilabial sound, which are those m. So these sounds should be clear, like v, which comes out. Now v and f, these are the words where the lip will come as close as possible, but it will not meet. So we need to check those areas. We need to check for the Silverman's closest speaking space by asking the patient to speak ch, th, and s, s. Now this s sound again plays a very important role. Now when we ask the patient to speak s, that means 66, any word which is starting from s, like Mississippi. So these kinds of words, when the patient will speak, will have an effect of the two incisors coming as close to as each other but not touching. So that particular space is called the closest speaking space, given and introduced by Silverman. And that space is very much different from that of freeway space. We know till now about it, because freeway space is the physiologic rest position phase, whereas the closest speaking space is when you ask the patient to perform any function. In phonation, the space which is present, that is the closest speaking space. So we need to see if these words, these letters are very clear with the patient. Also, if there is the rim width in the maxillary anterior region higher, more, then what will happen? The tongue, which was supposed to go in the rugae and come out with some words, will not be clear, like k, th, d. These are the words which the tongue tip goes to the rugae and then it produces these words, or the lingual parietal part of the incisors. So we need to even check for those words. If those are not clear, that means there is a wax present on after the parietal surface of the incisors and over the rugae. You need to clear that and see for the clearance of the voice and the phonation. Most important thing other than all signs apart is the approval of the patient. At times all your signs fails, but then if the patient says, no doc, I want this kind of teeth only, you need to keep your signs aside and go according to the patient's will, expectation, because at the end of the day, it is not you who is going to wear the denture, it is the patient who is going to use it. So in that case, if the patient desires are very much ahead, like they can say, no, I want my central incisors to be a little down, one central incisor to be out, weird expectations of the patient, but yes, maybe that patient is satisfied with those kind of looks, so you need to give that kind of look. So based on the patient's approval, you need to finalize the try-in stage in the patient's mouth by asking the patient. Also, if there is any relative accompanying the patient, and it's very important in try-in stage, you ask the patient to get a relative along with him or her. Sometimes the shade that we gave the shade to the patient, maybe A1 shade, a B1 shade, a very bright shade, but the patient says, no, I want a little yellow, doc, because my older teeth was yellowish. So you need to go ahead with the downing the shade and give the teeth of that particular shade which the patient desires. Nothing, all science which remains true and valid until the patient is satisfied. So try-in stage is exactly where we can do all corrections before going to actualization. Thank you.